Hello, my name is Vivian Vasallo. I'm the Executive Director of the Delta Dental Institute. We're a nonpartisan organization based in Washington, D.C., and focused on advancing oral health for all Americans and ensuring that oral health is a central part of national health conversations. In partnership with Delta Dental companies and community partners across the country, we support oral health research, community programs focused on oral health, and advocacy efforts to improve access to oral health. We welcome you to our inaugural conversation series, a format designed to bring the voices of oral health experts from across the country to create a dialogue of the issues that impact oral health. Our first conversation seeks to shine a spotlight on the importance of oral health and the need for federal government agencies to prioritize it by appointing oral health experts to senior leadership positions, as well as increasing support for oral health research and programs. This conversation is sparked by research that the Delta Dental Institute conducted late last year and around a campaign that we subsequently launched. Joining our conversation today, we have two nationally recognized oral health experts, Dr. Leah Devlin and Dr. Joe Dill. Dr. Devlin is a professor of practice at the Department of Health Policy and Management at the University of North Carolina Gilling School of Global Public Health. A licensed dentist, she has more than 30 years in public health practice in the state of North Carolina, including 10 years as the Wake County Health Director and 10 years as the State Health Director for North Carolina. Dr. Devlin is also chair of the CDC Foundation's Board of Directors and is also a member of the Delta Dental of North Carolina Board of Directors. Dr. Dill is the head of dental science at the Delta Dental Institute and brings more than 30 years of experience in the field, including 8 years in private dental practice and 16 years in the dental benefits industry. Prior to joining the Delta Dental Plans Association and the Delta Dental Institute, Dr. Dill served as Vice President of Professional Services and Dental Director for Delta Dental of Virginia, where he led the clinical professional services, dental policy, utilization management, fraud and abuse, and quality care areas. Earlier in his career, Dr. Dill spent 2 years working for the U.S. Public Health Service as a commissioned officer, where he provided dental care to residents of the Fort Peck Indian Reservation in northern Montana. Following 8 years in private practice, he founded a startup medical device company to develop a reliable means of diagnosing otitis media in infants and children. We will be discussing how the need for more senior oral health leadership and investments in research and programs at the federal level impacts not only state and local governments, but also the individuals receiving oral health care. Dr. Devlin and Dr. Dill each bring unique perspectives from their experiences at local levels, as well as having worked with organizations with a national scope, and will help us better translate how what happens in Washington can help or hurt the oral health care of all Americans. Dr. Devlin and Dr. Dill, thank you for joining us. A little bit about our research to provide some context for the conversation. Last fall, the Delta Dental Institute reviewed federal agency staffing from the years 2012 to 2020, and we examined 12 federal agencies that have the greatest impact on oral health. While oral health is essential to overall health, historically it has taken a back seat. We found a concerning lack of oral health experts within them, especially at senior levels, and as compared to counterparts as chief medical officers. We also found federal agency funding for oral health initiatives disproportionately low, and found that many agencies don't break down their oral health funding at all. Federal agencies subsequently publish fewer reports and policy briefs on oral health as compared to oral health topics, indicating a troubling lack of attention to oral health. With the new administration making new appointments on this daily, we are encouraging the new agency leaders to recognize oral health as part of an essential part of overall health, and that any agency that oversees health initiatives should have oral health expertise at the highest levels. And recognizing the many voices already within government in oral health, how can we amplify and elevate those voices? So given that context and our research, wanted to ask you in our first question, one of the things that might be surprising to some is just the breadth of oversight that federal agencies have in oral health, including agencies that one might not think of immediately when it comes to that topic. For example, the Environmental Protection Agency, not perhaps top of mind when people think about their oral health, but an agency that provides oversight to clean water and even the disposal of wastewater in dental offices. So given your experiences in this field, can you share what it's been like in your engagements with federal government oversight of oral health, and either examples of where it's been successful in shining a spotlight on those things that are working, or where there have been gaps and that's perhaps been something that has been hurtful to the area? And Dr. Devlin, we'll begin with you.
Well, thank you, Vivian. It's really nice to be here with you and with Dr. Dill. And you raise a really important question about federal leadership in improving oral health across the country. My experiences at the state and local level in governmental public health has primarily been with clean water, as you mentioned, with EPA, making sure we have community water supplies that are fluoridated. Also making sure that we're working with our Medicaid agency on coverage for children, which is more standard of care than coverage for adults. Making sure that rates allow participation of providers. So that's a very important agency. The work that is done through CDC is really critical. They are able to fund about 20 states. We have we have 30 more states and 6 territories that are without federal resources. But the work that they do in the states is really important with sealant programs in schools, with the efforts to continue community water fluoridation and providing good surveillance on the data. Who has oral disease? How does it impact some communities more than others, which we know that it does. So I think that elevating those voices is really, really something that we need to pay a lot of attention to. And of course, HRSA also, very important agency in terms of funding through maternal and child health programs. And I'll let Dr. Dill address some of the other agencies that are doing this good work.
Yeah, well, thank you. And thank you, Vivian and Dr. Devlin, for having me here. It's a pleasure to be here. Yeah, clearly the federal government can have an enormous impact, as you said, Vivian, good and bad, for a lack of attention sometimes. Clearly funding is huge for all the programs that Dr. Devlin was talking about, that school programs, school-based programs, community-based programs. You know, one of the experiences I had was actually getting a scholarship and a free ride through dental school from the federal government and the U.S. Public Health Service, National Health Service Corps grants. And that program put me onto, as you mentioned, a Native American reservation in Montana. And I was the only dentist for probably 100-mile radius for those individuals. And so those kinds of programs were really critical for addressing the inequities and the lack of access for particularly not only rural populations, but the indigenous folk, people on the reservation. To this day, what happened is during the Reagan administration and the period of small government, those programs were cut. And to this day, I think the closest dentist to where I was is still about 40 miles away. And I'm sure the specialists are still all in North Dakota. There weren't any nearby in Montana. So the federal government can have an incredible impact on so many different aspects. It's difficult to pick each of those organizations. And some of the organizations that you might not think about, like HUD or Housing and Urban Development. We talk a lot about the social determinants of health and food insecurity, housing insecurity, things like that really have a huge impact on health outcomes. And so sometimes it's not always easy to put those pieces together, but housing security, significantly improves health outcomes. So agencies you don't always think about. Like you said, the EPA, it doesn't come to mind that that's oral health related, but it can be.
You've both brought up some really great examples of the breadth of oral health in federal government and some of the opportunities where we highlight, for example, CDC in 20 states, but we have 50 states, DC and Puerto Rico in our territories, so we don't have full coverage. We talk about how oral health is embedded in food insecurity and social determinants of health. We have chief medical officers in these agencies advocating for overall health, but we're lacking chief dental officers at senior levels in many of these organizations. And this has been something that's historical. Our research went back to 2012, but I suspect that if we go back a little bit more, we would find also similar vacancies throughout federal government. What is the risk of not filling these vacancies, these positions that exist? We have a real opportunity right now with the new administration and new leadership to really advocate for these vacancies being filled. What happens if we stay the course and we continue with these vacancies? What is the risk for overall health and what is the risk to oral health?
I would say that having the expertise in the agencies at the federal level is really critical, and having that voice of the dental community, the oral health community at the highest levels where the decisions are being made is really important. Those experts have the data, they have the knowledge on best practices, they have the opportunity to throw out innovative strategies that have worked in some communities that maybe need to be disseminated across states and across the nation. And so the voices at the table really matter. And in my own experience, having a leadership team at the state, we always had our lead oral health expert at the table. And it made a huge difference because others don't always know the data. They don't always know that oral health is a part of total body health. It's not top of mind. So having that voice where decision-making happens is really critical. And if you look at the incidence, the amount of tooth decay in children, 20% of our children have at least one tooth with decay in it. Adults, around 26%. There are other diseases. I mean, this is the most important infectious disease of childhood, and we must address it. And so to do that, it has to be a priority, and that expert at the table can make it so.
Yeah, I agree. And, I think having that expertise at that decision level, and to be clear, many agencies do have oral health experts within them. For example, the CDC has an oral health division. So it's not that they aren't there. It's just that they're often not at the decision-making level and at the input when plans are implemented. And one of the things, the dental delivery model is just different than medical. And so past experience working for a medical carrier where dental benefits were sort of a ancillary benefit. They were sort of out to the side of the medical benefits. They didn't often think of dentistry as anything more than just sort of mini medical. But if you think about the medical delivery model, 90% of physicians practice in large physician groups and hospital systems. They participate with the hospital systems. In dentistry, it's still 70% are solo practice, single dentist offices. So the delivery model is completely different. So if you try and overlay a medical model onto dental, it often fails. And that's the kind of voice we need in those. I think about the risk of not having that expertise. We did some polling, and almost 90% of Americans believe that Medicare should have a dental benefit. And a lot of Americans don't even know that Medicare doesn't have a dental benefit. Also, think about the plan design. The senior population has different needs than the child population. So plan design and sort of individualizing in a way the plan design for that population is going to be critical, and understanding how dentistry is delivered and how it's different than medical is critical.
No, that's a great point that you both raised, and it leads me to think about the other side of this equation, which is the lack of research and data and support for programs. So the allocation of budgets to oral health, and part of that is perhaps not having that voice at the table. But as you say, absent that voice, there are other things that agencies could be doing, including support for research. And so are there any programs that maybe come to mind that would benefit? We heard a little bit about the CDC's programs in 20 states for oral health. Are there other areas where you have all seen gaps in either research or programs that could be scaled with more resources?
I think that the NIH, the National Institute of Health, which does so much funding for research, only just above 1% of their total funding for research goes to the craniofacial research, the dental and craniofacial research. That's a pretty stark difference or dearth of funding for oral health when you consider the breadth of the NIH. And I think one that's close to home for me is the Veterans Administration. I think that not only in terms of research, but in terms of supporting dental care delivery to our veterans, it's kind of dismal in the country. It's been a kind of a failure, I believe, that our veterans aren't better taken care of, and there aren't dental clinics in every VA center, and not all veterans have access to dental care. And I think that's one of the areas that, in my mind, that really needs to step up to the plate and concentrate more on oral health. As Dr. Devlin said, that the mouth is not some separate organ outside of the body. Oral health is health, and you can't separate the two.
I think that really is underscored in coming out of the pandemic, how much we've heard about the stress and the impact that has had on people with their teeth, and the mental and dental connections, and really the lack of information that was out to people last year during the pandemic around their oral health, but yet we saw the impact that it was having on their overall health.
Right.
I wanted to go back and touch on the research again just for a minute, because I think that Dr. Dill, you sort of framed it as, issues related to not only new technologies, but also into how we deliver care and who's outside of the care that we currently provide, mentioning veterans as one example. And I think that's a great way to frame it, because we've seen investments in North Carolina in terms of new innovations, and we're leaders in the Into the Mouth of Babes initiative, where we work with Medicaid, we work with local providers and the public health practice community to explore new ways of protecting baby teeth. Dentists are the first preventionists. So we've long been engaged in, brush your teeth, see your dentist twice a year, avoid sugary foods. But we need to be sure that everyone has access to that. And this new technology was instrumental in bringing in other providers that could help protect baby teeth in children, which sets them on a life course of better oral health. Sealants, which are over 85% effective, came on board many, many years before that. We still need to expand our sealant programs in the schools, making sure that historically marginalized children have access to sealants. New technologies like silver diamine, which stops decay in its tracks, it's incredible. And of course, fluoride, and making sure we continue to use that technology, and how we can continue to have educational efforts to support community water fluoridation and the technology to make that simple, cost-effective as it can be. So technology is one area, but also access to care is another really important point, where we mentioned that we need healthcare coverage, so people have access to care through Medicaid, through Medicare. Maybe the private plans can expand their markets as well in an affordable way. And then there's a whole set of workforce issues that needs to be looked at in terms of research and how states manage access to care through the workforce. Many of the services that we provide in dentistry, I talked about dentists being the first preventionists, but many of those preventive services actually need to occur in a dental office. So we've got to get them into care, and we've got to be able to provide the resources to do that. I work at one of the, at UNC at Chapel Hill, which has a top school of public health and a terrific dental school as well. And we really rely on that research, knowledge, and expertise of NIH to give us the fortification we need to bring these new technologies and new systems of delivery to market.
As we are talking in healthcare more around this issue of prevention and these conversations around, again, pointing to the pandemic and how those that were in good health to begin with suffered less than those than aren't. And so how do we really look at the system as a whole? One of the things that we know is that oral health literacy, as well as health literacy, is very important, right? As we've tried to figure out all of this health information over the last year, it's been very challenging. And so how to help people understand what they need to know about COVID, for example. Now with the vaccine, we're seeing a lot of information, mRNA, for example, with the vaccine, something many of us weren't familiar with a year ago, and now we are more so. When we think about oral health literacy, we did a study last year, and that was around improving America's oral health literacy, finding that there were discrepancies in oral health literacy and that it was very much still at low levels. When we think about oral health literacy at a policymaker or at an agency level place, what do you think are the levels of around oral health literacy and the understanding of that, and what could we do more to, again, as you say, help people better understand oral health and have a higher oral health literacy levels, even those that are in the decision-making roles, in order to impact the research and to have that translate into support for more programs? Again, some examples around the workforce level, sealants, prevention for children. What could be done to increase that oral health understanding at the federal level?
Great question. Going back to do policymakers sort of have the level of oral health literacy that may be required? It's interesting. We did some polling at the Institute and at DDPA that 92% of the people polled understood and believed there's a connection between oral health and overall health. And they understand that concept. But when we took a little deeper dive and asked them, well, do you believe that diabetes is connected to oral health, and oral health connected to diabetes, or heart disease or kidney disease? And when we started looking under the hood a little bit and got into more details, that 92% started getting to 60, 50, 40%. Were actually agreeing with that. And so to the extent that policymakers are representative of the population in general, unless the policymakers are health experts themselves, we can kind of expect that level of health literacy in the policymakers as well. And I think one of the challenges at the policy level has always been, the budget constraints. We only have so many dollars to work with. So that's always a constraint as well. And dental is always the first thing that gets cut, because that connection, that understanding that oral health is health isn't there, and they don't connect the dots. So for example, in Medicaid programs, you see it all the time. When there's difficult economic times, the first thing that's cut is adult dental benefits in Medicaid. It's an easy thing to cut. It shows that, oh my gosh, we can save X millions of dollars by cutting dental. But that in America, over 2 million visits annually to the emergency room are for often preventable dental disease related issues. And a lot of that has to do with oral health literacy, not understanding the importance of preventive care, but it's also, the vast majority of those folks that show up at the emergency room don't have dental benefits. They don't have dental coverage. And what's worse is when they go to the emergency room, they don't treat the root cause of the dental problem. They treat the symptom and the sign. So maybe it's antibiotics for an infection and pain medications for the pain. But that doesn't solve the problem. And so it just perpetuates it. And when there is no adult dental benefits, emergency room visits increase. So it's often that misunderstanding of not understanding the connection, but also when they're looking at budgets, those dollars that you're saving on the dental side are ending up getting shifted over to the medical side in many cases. So that's always been an issue, I think.
Well, and the only thing I would add about working with policymakers or others to help them appreciate the importance of good oral health as a part of total body health is you have to have the data. There's no question. I mean, this is a science of public health and access to care. There's data and you've got to have it. But there's also the story and the picture that goes with it that can, motivate, inspire, and convey knowledge. For example, a child that has tooth decay that perhaps is in pain. First of all, poor oral health is going to affect their ability to speak, their ability to eat. We mentioned good nutrition. It's going to affect their self-esteem and how others view them, how they're treated maybe by their peers, their self-concept. It's interesting that we expect children who may be in pain or who are in pain to be able to sit in class, be still, pay attention, learn, go home and do their homework. We wouldn't be able to do that as adults very well. So we know that good oral health correlates with success in school, and poor oral health, the grades go down, attendance goes down. Poor oral health is one of the main reasons that kids miss school. So that's just, something to help. The stories of kids with untreated dental decay can help motivate policymakers. And it's true with adults too. I mean, we expect people to be employed, but it's very difficult to get a job if you don't have a presentable smile. So, and that affects your self-esteem and how you present at your interview and on and on and on. So good oral health is important for success in life, I think, is the bottom line.
Yeah, and I think Dr. Devlin brings up an interesting point about the sort of that mental health connection too. We sometimes, in the past, I think oral health is where mental health was maybe 10 years ago, because the policymakers finally started to get the idea that mental health is all part of health as well. And tooth loss is one of the predictive factors for a dental disease in adults, periodontal disease. And my experience, I volunteered at Mission of Mercy events where they go in and set up these huge dental clinics for 2 days, and people stand, for blocks waiting to get in to have their unmet needs met. And one of the stories that I always heard were from people who came there and said, I really just want to have my teeth replaced so I can go to that job interview and get a job. And the other aspects of mental health, when you're missing teeth, for example, you don't smile. You tend to avoid social interactions, and it can lead to isolation. So the mental health piece of it is so critical to health outcomes, and oral health, mental health, overall health, it's all the same thing.
We kind of separated the head and the heart a long time ago, and we've just got to do better. And as you say, we've done better with mental health, and we've got to do better with oral health. The other point that you make that reminds me is that this generation is going to be the first generation of seniors that will live out their lives with their dentition, their teeth actually intact. And that's great news. It also gives us an opportunity and a challenge. We have to help them take care of their teeth and their periodontal, their gums as well, so they can stay as healthy and age as well as they can, because we're going to live a long time with those teeth. So we've got to make those investments in healthy aging, which should include oral health.
I feel like what we're saying is we need to put the body back together again in healthcare and treat all aspects of it. Why and how it got separated, is a topic for another conversation series. I'm based in Washington, D.C., and I think, one of the perspectives I have is that our government is our citizenry, and that it takes all of us coming together to address and tackle these issues. And so I really want to give credit to some of the work that is happening in the federal government and really advocate for more attention for oral health. But also invite you to provide some suggestions to how organizations like the Delta Dental Institute and others could work together to really advance oral health as part of overall health, whether it's in federal agencies or in various oral health programs. What can we be doing to play a greater role in shining a spotlight on these issues? How can we come together, different sectors, to, again, really advance solutions, and knowing that we can't put it all necessarily on one agency or one organization, but really in partnership together. Any thoughts on that, on what either the Institute or others could be doing?
I think that in terms of the Institute, conversations like this are important, and this is a start. And I think, it's around advocacy, having conversations like this, keeping oral health sort of top of mind with policymakers, and really shining that spotlight on oral health, and to constantly remind our policymakers through advocacy that oral health is overall health. And it's not just with our policymakers, but also community leaders, that those programs within the community that are working with different communities within their towns and cities that are having success. And I think that the other aspect is community involvement. So organizations like ours and others can spotlight those successes at the community level and raise them up for possible adoption across other communities. If it's working in one community, it may have some applicability. At the end of the day, I think we also have to be realistic around federal agencies, what they can and can't do, because everything's local. And the local leaders, local people really understand their communities, and they understand what's going to work best. So I think one of the things federal agencies can do is not put so many strings around the money and requirements that X% has to go to this, X% has to go to that. Give the local leaders and the state leaders the flexibility to use those funds that they know work best in their states and in their communities.
Great. Well, Dr. Devlin, as someone at the state level, reactions to that and other thoughts and ideas?
So I believe working at the federal level, raising the visibility there is really important. And we've mentioned that there are 12 different agencies that have an impact on oral health. We do have Healthy People 2030, which is the federal government's and partners, state, local plan. And there are oral health metrics there. So we have a plan, we can get around it. Some of it requires funding, but not always. I mean, you mentioned working at the state and local level, that everything happens in community. And I agree with that. In North Carolina, when I was there, we had very rich partnerships with the community. I was lucky that we had a strong dental public health program in North Carolina. We also had partnerships with the Dental Society, which was actually instrumental in over 100 years ago, helping to start the dental public health program in government. We had strong partnerships with the academic institutions, UNC, Chapel Hill in particular, which I mentioned earlier. And we still have one of the oral health residency training programs there for the public health workforce. But we have a strong way of working together in our state. And I think the more that the Institute can encourage partnerships across the federal level, the state level, at the local level, and between those different sectors, it would be very, very important. You can do things as the private partner of private-public partnerships that government can't do, like have these conversations, like ask the federal government to lift the voice, to raise the awareness. We've got to change mindsets is what we're talking about. And once we can change mindsets of policymakers, community leaders across the board, then the rest can flow when we truly understand the importance of oral health. So I think that's really, really important.
Great. Well, thank you both. I think, as Dr. Dill said earlier, some of our Institute polling really shows that the majority of Americans can agree on oral health as being essential to overall health. And at a time where we're looking for areas of unifying our country, I think we can all be really passionate about having a healthy smile, not taking for granted the simple nature of turning on your faucet and having clean water in the morning and being able to brush your teeth. Those are preventive things that are simple but yet so impactful. And I think how we can come together to build on those areas and really have some robust conversations that lead to impact that will affect overall health. Again, those are things that our polling and our data shows that are very much in favor with the American public, and also I think as policymakers very receptive to that message. So Dr. Dill, you had mentioned how early in your career you were in a tribal community area where there was very little access to oral health professionals and dentists for miles and miles, and that's a situation that's faced not only in rural areas, but also, I suspect, in urban areas with people lacking access. We've seen the pandemic really amplify the disparities that exist in healthcare and continue to exist through vaccine dissemination. Could you all briefly talk about the role that equity plays in oral health and where we are maybe falling short and where we could have greater progress and influence?
Sure. And, my experience on the Native American reservation was, formed my first impressions of health inequities in this country. I mean, I grew up in the San Francisco Bay Area, went to dental school in San Francisco, and I certainly knew some people couldn't afford dental work, but there's Medicaid, we have safety nets for that. Very naive. And when I went to the reservation, it was very stark, the inequities that were there. And inequities in terms of access to dentists. Without the public health program, there would not have been a dentist in that town or anywhere near, as I mentioned. So that was both a rural aspect. It was also, kind of within the culture, an education level that creates disparities. And we talked about oral health literacy. On the reservation, oral health literacy was really quite, the dental IQ was quite low. There was still a belief that, to calm a crying baby, you just put them to bed with a bottle of Caro syrup and water, so sugar water. I'm sure that worked really well to calm the baby down and help them sleep, but it also destroyed their teeth. And it was very difficult. And it was one of the things we did first off on the reservation was try to increase the oral health literacy. And we worked with the tribal government in developing some pamphlets and some posters and such that really kind of dispelled that myth that was a good thing to do, the Caro water and syrup, or Caro syrup and water. And so, yeah, it's the inequities occur in so many different ways, and it can be cultural, it can be ethnic, it can be economic. And so there's certainly no one solution for all of it. But as Dr. Devlin said, the COVID pandemic has really, really opened a lot of eyes to oral health and just general health inequities, sort of the way it opened my eyes when I first went to the reservation.
Let's talk about children. They're twice as likely to experience oral health problems if they live in poverty. So you can look at the historically marginalized populations in community. And we've been working, you had asked about the CDC Foundation. And the CDC Foundation, one of the things that the pandemic, everybody's talking about equity, right? Because the pandemic really focused the problem of lack of access to all kinds of care, including a vaccine, but it's true for oral health for historically marginalized populations. We have to do better about that. sometimes that's not always the most, compelling argument, but it's the truth. And it's also a rural health, which we didn't mention at all, access issue, and how we put, how manpower issues play out across the state, whether we have enough or where they practice. And so people have access. We have counties with no dentist at all in our state, and it's been that way for years. That's one thing. The pandemic has gotten everybody's attention. We may have a new opportunity to address equity issues in oral health care.
The experiences that people have and the diets and the culture very much impacts our healthcare and our oral health. And how do we translate that again into information that people can use in a way that impacts their health? We've learned over the last year, simple things, washing your hands, putting on a mask, keeping social distance can really prevent or reduce the prevalence of this very dangerous virus. How do we get those messages and other aspects of oral health, and how do we translate it into communities that have that disparity? I think is just as important as the allocation for research and dollars and having that voice. So I think that this pandemic has, again, amplified what many of us in healthcare know has been the case all along, just that inequity exists, and that how we introduce solutions, as we're seeing even with the introduction of the vaccine, we have to be very intentional with that equity. And so I'm excited to explore this topic further. I think it's one that's very important and that merits, again, more conversation and more solutions to this space. So before we close, wanted to just ask you if you had any last comments, any parting words, any words of wisdom to leave us on as we close out our conversation on oral health in federal agencies.
No, I think we've sort of amplified and explained and gave examples of why it's so important to have the oral health experts at the table when the decisions are being made.
I think it's really important to get children into care early. This is an entirely preventable disease. If you can have access to community fluoridation, access to quality preventive services like sealants and regular dental checkups, we can catch problems early and begin to set children on a path of success in their health and in their education for life. And it is a lifetime issue over time. So we do have to address it over the lifetime, but getting in early is really critical. We have the solutions. We know what to do. It's getting the will to make the investments in good oral health programs for all.
Well said.
Well put, agreed. Well, again, thank you all for this wonderful dialogue and your contributions to our inaugural conversation. We invite everyone to learn more by visiting our website, www.deltadentalinstitute.com, where you can find more information on our research, advocacy, and community impact efforts. And thank you for joining us.
Thank you.